distance on the right, so the vertebra is tilted. You could also draw lines on the bottoms of the end plates of the vertebra as well. Here's what I did with my system, and that's one of the things I love was on that Cobb's angle. You can click, run along the bottom of one, click again, run along the bottom of the other one, hit a button, and it shows you how many degrees. So I could say there's a 12.57 degree lateral flexion subluxation of L4 and L5, and then I'm sure Medicare would be very happy with me. You can measure the intertransverse distance. You can see again with the radiometrics on your computer, you click at the bottom of one, click at the top of the other, go to the other side, and all the measurements just pop up by themselves. In fact, I brought the DICOM program, a very simple free download one, on this computer. If we have time, I can play with it, but really that's what the main part is. You can also take a look at rotation of spinuses. So if the spinuses aren't lined up, you can say that you have a rotary subluxation. You can talk about anterior or retrolisthesis as subluxation, or lateral listhesis. If you have a decreased interosseous spacing, a narrowing of the disc, you can call that a subluxation by altered interosseous spacing. And then you have the kinetic. Those are all static. Those are all just ones you can see on a plain film static. But if you do dynamic x-rays or kinetic x-rays, then you would take a look and say you have a hypomobile segment. In other words, that vertebra during flexion of the neck, that particular vertebra at 1, 2, 3, 4, C5 is not moving. So that would be a hypomobile subluxation. If you put them in flexion and you see an increase in the interspinous distances, you could call that a hypermobile subluxation. You can see if the person goes into flexion and the vertebra moves into extension, aberrant motion subluxation. And you also have regional subluxations, like a scoliosis. You wouldn't have to pick the vertebra. You could say there's a scoliosis and vertebral subluxation. I'd still put it in there. From T3 to T11, measuring so and so many degrees if you want. Scoliosis, alteration of curve secondary to structural asymmetries, decompensation of adaptional curvatures. So hypokyphosis in the neck or hyperlordosis in the neck or any of those things, those are all considered subluxations. So what I did here is I put one of my reports, chopped it up and stuck it in here. So you can sort of see the wording that I used. But then we're going to actually look at some x-rays, and I'm going to ask you to just figure out what kind of alignment. We're only going to talk alignment issues that you might see on these films. So in this case, I put CR, radiographical examination, including 5 views of the cervical spine was obtained. Views included, so you list the views, you list your KVP, your MA, or MAS. No, it's MA because the S is 0.3 seconds. And I noted that the patient had some metal clips in her hair. I didn't notice them when I took the x-ray, but after the x-ray was processed, I saw them, so I mentioned that they're there. And I also put in there that I gave a copy of the image on a CD-ROM to the patient. You all remember the ABCs of reading an x-ray, right? A is for alignment, B is for bone, C is for cartilage, and S is for soft tissue. This is a really, really handy thing. You look at the x-ray 4 times. You know, first time you scan it just for alignment. Don't let your eye focus on one thing, because that happens when you see the gas bubble or whatever. It's hard to see anything else around it. So under alignment, I usually start off with this statement. It's almost the same in all of them, except if it's not true. The vertebral bodies have grossly normal height and alignment. The discs are normal width. There's a mild left convexity in this case with level mastoid jaw lines. Intervertebral alignment is grossly abnormal with multiple subluxations noted primarily in the lateral cervical. So that's just a general statement. Now here's an open mouth view. And I use this one because it's the only one I ever got perfect. They're the hardest ones to get. But you can see on the CR film, you can see what I talked about, her hair, braids in there. That's not brain. But you can see the mastoids are level. Really a good looking open mouth view. I got everything in there. The incisors always look like a split in the dens, but it's not. Okay. So let's focus on alignment. I'm going to pop up an x-ray, take the note paper, I think they give you all a pen and a pad, and just jot down how you would describe this to Medicare. So we'll start with this one. Same person. These are all the same person with the hair clips. And while you're doing it, I'll just make a comment or two. You notice on the CR X-ray that not only do you get good contrast between the bone and the dark here, but you also can see the muscular layers. And that's because the computer knows this is soft tissue and it actually changes how it develops. That's why even if you turn it up higher and higher and higher, all you get is more detail in the soft tissue. So you could see where you'd crank up the machine beyond what you should because you wind up dosing them more, but the picture just gets better and better and better. So if we take a look at how I worded this, what I saw, see if you agree. There's a mild left cervical convexity, so a slight cervical curvature. There's my right marker, so the convex side is on the left, between C3 and 6, with a resultant sectional cervical subluxation. So boom, I'm done. I've proven my subluxation in Medicare. I don't need any more, but I will. Okay, next one. These are all pretty typical, aren't they? This is a young woman, and see this all the time. So just quick note on how you would describe this. It's even a good dental film. So deep roots. Okay. There's a mild cervical kyphosis noted involving cervical vertebra 4 through 6 with a resultant extension of the atlas C1 and axis C2. Also demonstration of chiropractic extension subluxation. So essentially I'm saying that this atlas looks to me like it's back, like it should be a little bit more horizontal, and it still has a little bit of an angle, and you'll see it more in the balance of the films. So here she is with flexion. Almost missed this shot. Almost didn't get C7. Okay, and what I noticed on this one was the atlas and cervical vertebra C2 and 3 and even 4 stay in extension. And you can go back and look, and there's no difference in the distance between the atlas and the occiput and the atlas and C2 in flexion, and that should open up a little bit more. So it stays in that extended sort of position even though the neck is flexing. So what you see is this straightening or almost extension, and then right here, C4, boom, that's where the curve. So instead of it being a nice smooth C curve, it's more of an open V with this C4-5 being the main point in the middle of it. And here's extension. And now, of course, on extension, you can see as the skin folds, the atlas and occiput approximate, the atlas and axis approximate. In fact, all of the spinuses approximate. So extension looked fine. Neutral and flexion looked screwy. With the cervical extension view, it's within normal limits, except C5 posteriorly inferiorly, there's translational movement by a break in George's line. So if we look close up, this is what I was talking about. The back of the vertebra, nice and smooth till we get here, a bit of a jump. So I consider that a subluxation. Point them out everywhere. Medicare doesn't care if they're paravertebral subluxation, so if they're of the ribs or costotransverse relationships, that's fine. Sacroiliac subluxations are okay. Here's one. You can see this listing, more of a listing than a scoliosis. It's like everything's level, or at least the pelvis isn't, but L5 looks pretty level, and then L4 just has a big lateral flexion subluxation. The whole spine takes off from there. But the point of this was pelvic subluxations. And you can see here, if you just measure the spinous to the ASIS or PSIS, you'll see that it's rotated. So I'd call that a rotary sacral subluxation. And you can measure it digitally with your new toy. If you're going to demonstrate X-ray by exam, then the definitive chapter is actually in my textbook, but you can get copies, I'm sure, of just the Bergman chapter anywhere, or just look at what Medicare says, which essentially is that you must have 2 of these 4 things done. And one of the 4 has to be asymmetry or range of motion. So basically what they're saying is you have to document pain. This is all at the level of the subluxation. So let's say I'm saying it's C4. So I have to say C4 has pain or tenderness. I have to say C4 has a subluxation misalignment and then identify it, sectional, or just say C4 subluxation. I then have to show that range of motion is abnormal involving that area, C4. And then I also have to put, or I can put that the tissue around C4, that the paraspinal tissue was hypertonic, and all those indicate the subluxation. Now the way Medicare looks at it is, well, you don't have to have all 4 every time. All you have to do is always have either A or R, and then one other one. So you really only need 2, but one of the 2 must be the A, asymmetry, or R, range of motion. So the only ones that you'd never really have to have would be P and T. So you don't need to show pain, and you don't need to show tone and tissue changes. But to make them happy, I did all 4 every visit. Because the one thing Medicare doesn't tell you is how you have to describe it. So you could just say, pain to palpation C4. That's it. You don't have to go beyond that. You don't have to say pain on 2 of 5 scale or sharp, achy pain. Just the minimum, pain. Asymmetry, that's all I have to say. C4 shows subluxation. And you can put rotary or flexion, whatever you want. Range of motion, you just have to say range of motion involving cervical spine abnormal. You don't have to measure it. You don't have to put numbers. So you can make this a lot faster than it looks. And under tone and tissue, you could say paraspinal muscles were hypertonic in the area of C4. So you don't have to get into great detail, but you have to address these points. Now, as I said, you don't have to address all 4. You have to pick 2, but one of the 2 has to be AR. So in order to just make that, again, it's just confusing. So just do all 4, and then you're covered. So basically they're saying this is the physical examination and you're proving subluxation by showing those 4 parts, or the 4 things in the part analysis. You must document 2. Either the A or the R are required every time. P and the T are optional. So here's a question for you after all that. If your records only had 2, which of the following would not constitute an office note sufficient to document a subluxation? Very good. All right. Boom. Very good. 85% of you got that right. The P and the T would be the ones that you wouldn't need to have. All the other, would be insufficient for proving a subluxation to Medicare. All the other ones would be acceptable. Okay, let me take a peek. All right. Just going to go about 10 more minutes and then we'll break. History of present illness. This is, I'm going to give you a quick way. If you're sitting in the room with a patient and you're going through the history and you're thinking, did I cover everything? Some of you may have heard of the term DOLCAT. It's just a stupid mnemonic, but it's worked for me for years. So just remember that you have to get the duration of the complaint. So, Bill, when did this start? You have to get the onset. It started 2 weeks ago. Well, what were you doing? Oh, I was lifting boxes, so that's your onset. Where does it hurt? Location. Oh, it's my right side of my low back. Is it a sharp pain, a dull pain, achy? Does it radiate anywhere? Then you have to say what makes it better, what makes it worse. So that's the A, aggravating factors, and then T, have you been treated? Have you treated yourself? How did you respond to the treatment? So if you cover that, you pretty much have a good history. Now, Medicare elaborates on a lot of these points, but basically that's what you need to do, DOLCAT, for a good history. If you look at Medicare, they go through the same thing. They say what symptoms are there, what family history. So these are things that you can pick up with a form. You don't need to ask the patient. You can hand them a systems review, and it'll have family history on it. Past health history, that's also on a form. How many surgeries? You don't have to sit there and ask them, so when you were 19, you had your appendix out. Then I went on to the gallbladder at 52, and just go on and on. What mechanism? Well, we said at onset. Quality and character, that's covered in DOLCAT. Onset, duration, intensity, that's all really covered in DOLCAT. Aggravating and relieving factors, again, that's covered. Prior interventions, treatment, medications, that's covered. So again, they're breaking it out differently, but essentially that DOLCAT gets you everything you need. So again, the history, but after the history, they want you to describe any mechanism of trauma, the quality and character of symptoms, the onset, duration. It's the same thing, really. The symptoms that cause them to come in, you should always start with that patient is a 32-year-old male complaining of right-sided low back pain. Start with the simplest thing for all your notes. But for Medicare, they're saying that symptom in your opening statement must be related to the subluxation. So if they come in and say, I'm coming in because I have a twitching in my thumb, and you find a diagnosis of lumbar subluxation, that's not covered by Medicare because they're saying the reason the patient came in has nothing to do with the subluxation you found. They want to make sure that the subluxation you're finding is the direct cause of the symptoms that they're coming in with. And they do cover like ribs and pelvis and things like that, and they ask to document signs like swelling or spasticity or pain. But the subluxation must be the cause of the symptoms, or boom, not treatable, not reimbursable. And you always have to have that statement from the patient where the pain is located. Then, after you do your examination, so first you get where does it hurt, then you examine them and you come up with your true diagnoses. The first one is always subluxation. The second one is what you think is causing their pain. Now, if the subluxation is causing the pain, you can just put arthralgia as the second diagnosis, or even just have subluxation as both your diagnosis, as long as you've documented that there's pain in that area. So you could put cervicalgia, or thoracalgia, or lumbago, which sounds like a dessert or a meal, doesn't it? Like a bagel with lumbago sauce on the side. So it should be lumbalgia, but for some reason they changed that one. So you always have to put the level of the subluxation and that primary diagnosis as the subluxation, and then second to that, what's causing their pain, and then you're solid. You could use listing techniques too. You could say it's a right rotated left lateral reflex, or you could say it's a posterior, use a Gonstead listing, but no matter how you do it, that's not where they're going to pick you apart. Now, your treatment plan, that's where they will pick you apart a little bit more, because you have to state every single visit what your recommended level of care will be. So you have to say, I want to see the patient 3 times a week for the next 2 weeks. And you have to put that in they don't allow you, according to this one doctor, and maybe she was exaggerating, but she told me specifically they do not allow you to refer to a printed treatment plan, that you must have the treatment plan in the note every visit, which is insane. You have to state your goals, short and long term. So you have to say, chiropractic adjustment to decrease pain and increase range of motion, or increase functionality. I mean, stupid terms, but you got to put them in there. Long-term goal, increase quality of life, increase range of motion, decrease pain. I mean, it's the same stuff over and over. Then you should have an objective measure to evaluate your effectiveness. Now, this is where outcome assessment comes in, and I'll give a little spiel on that, and then we'll take lunch. When we come back from lunch, there's not much left of this, and then we'll get into the other subjects. But outcome assessments, I'm going to boil this down really, really simple. There's 3 main ones used in chiropractic. There's the Oswestry, revised Oswestry for low back. It's called the Disability Index, but has nothing to do with disability, really. Then there's the Neck Disability Index. That was created by a chiropractor. It's based on the Oswestry, which is a low back tool. Ask the same questions, but just ask them about the neck instead of the low back. And then there's the functional rating index, which was my favorite because you didn't need a brain to use it, because it covers whether it's neck or back or shoulder or foot. Doesn't matter, it's just a functional rating index. Now, the reason that we use these is because in the past, we were all told that what's objective, when we do our notes, subjective, objective assessment plan, the SOAP note, right? We were told subjective, that's what the patient tells us. It doesn't matter. Objective, that's what we find. That's the provable stuff. Research has shown that it's completely the opposite. That what we find is just dependent upon us, it's subjective. In other words, if you take a patient right now, and you put him in a chair, okay, and each one of us comes up and measures range of motion, and then sits down and we compare notes, the odds that any two of us would have the exact same numbers is very small. So range of motion, which we use all the time as an objective test, is actually not that objective, because it's subjective to how we do the range of motion. Same thing with straight leg raising, same thing with muscle strength tests. They just are not, you could use the term reproducible, but it's actually a better term for it. Because reproducible you use with experiments, but with outcome assessment you tend to use the term reliable. Okay, so it's the reliability that's important. How reliable is the test, and then validity. So, instead, you give the patient a questionnaire. Now, if I give you a questionnaire, or this doctor gives you a questionnaire, we get back the same questionnaire. So the reliability of what the patient tells you is actually super high. The reliability of you doing an exam is really low. And they call that inter and intra-examiner reliability, meaning even if I did the range of motion 3 times on the same person, I probably, if I didn't know it was the same person, I probably wouldn't come up with the same numbers. But if I do it and someone else does it, we definitely won't come up with the same numbers. Yet if 3 people hand a form, we're all going to get the same form back, like 97% reliable. So as it turns out, these forms are very reliable. So what do the forms do? They ask 10 questions. Each question has 5 answers. Okay? The first answer we call a 0. Second is 1, 2, 3, 4. So the maximum number of points they can get is 4. I'm talking the functional rating index. It's actually 5 for the Oswestries, but let's just stick with functional rating. So the question might say, when it comes to personal hygiene, I can, and the first answer for 0 would be, I can wash and clean myself with no additional problems. The 1 pointer would be, I can wash and clean myself pretty well, but sometimes it causes a little pain. And then you go up the line until the last one would be, I can't wash or clean myself, there's too much pain. So every one of them is a progression from perfectly normal all the way to as bad as it can be. So if there's 10 questions, right, and let's just say it's 5 points, even though it's just for math purposes, then the worst a person can get would be 50, where they answered the worst on every one, right? So you take that number, double it, and that's a percent. So if a person X'd off the worst choice on all 10 questions, they'd get 100%, right? So if you, let's say they walk in your door and you give them the form and they wind up with 80%. And then you treat them and they're at 70% the next visit. Now I would use this every visit. Now outcome assessment you need to do with every exam. If you only do it once, it's meaningless. Because 100 for me might be 2 for someone else. But 100 for me on Monday and an 80 for me on Tuesday shows I've gotten better. Do you see? So I'm comparing me to me, not to the world, just to me. So I would do it every visit. Now some patients don't like forms. So we'd have to tell them, well, it helps us be sure that your insurance company covers the visit, and then they'll do it. Unfortunately, Kathy figured that one out. So you give them the form, and you show it's an 80, it's a 70, it's a 60, it's a 50, and then you hit your 12.